Okay, this is the arterial decannulation scenario. So let's talk a little bit about the prep. We're going to have a long length of IV tubing connected to a reservoir of blood. It ends in a blunt tip catheter. And then you'll place that in the patient's neck and then thread the extra tubing so that it's behind the scenes. Our patient will be given a brief history with a visitor leaning over the patient such that it dislodges the cannula. The blood will start to be shown, and then the vitals will drop, heart rate will drop, blood pressure will drop, and sats will drop concurrent with the hypovolemia that's going on. And we'll be expecting our student to identify the bleeding, apply pressure to the patient on emergency vent settings, come off ECMO, and get extra help from the surgeon and the ECMO team.
You can simulate massive bleeding or oozing from the neck site by tucking the cannula close to the site through the skin, or you can lay it under the baby. Just have the tip close to where the cannulas are exiting. It's good to have gauze around so you don't have to clean up the mess after. Second option, if you have a mannequin without removable skin, is to just simply put the line under the neck and tuck it under with a bit of gauze just to sort of camouflage it, or you can use bed linen. And then just tuck the line under the baby. And the blankets. And your line should just camouflage in with your other lines. And then as I drop the vital signs, I'll be able to show that there's been a large volume loss, blood leak at the cannula site.
Okay, this is day one for a 2-month-old who had a witnessed arrest on the floor. A visitor with many dangling pieces of jewelry just left the bedside after giving the patient a kiss. I'll be available in the scenario as the bedside nurse again, and we have the real vitals displayed and the CDI gas output.
Okay. Do we have any labs to look at?
They've all been sent for this shift and they're pending.
Okay, great. Heart rate looks good, pressure's good. Oh, I have a venous alarm. The venous pressure is getting quite negative and servo-regulating the pump for me now. Flow's going down, coming up. Heart rate's dropping, pressure's dropping. Let's do a quick circuit check, see what's going on.
It's like our
Oh wow, look at the cannulation site. There's massive bleeding at the cannula site. Call the ECMO MD, call the nurse in the RT, and you know what? We need more help, so
here, I put some pressure here. I put us on the emergency vent settings.
we need to come off ECMO right away, clamping the arterial,
Okay.
clamping the venous, opening the bridge.
Okay.
Okay.
All right, Rock, I'm gonna hold pressure. You take pressure. I'll go ahead and I'll go ahead and give some volume to the patient.
Hey, can someone call the blood bank? We're going to need some more volume.
20 per kilo going in.
Great. Make sure the surgeon knows to come. Okay.
Okay, and I'm gonna give another output of blood here.
Okay, holding steady at sat of 80, pressure 45.
Okay, second output in. Nice job. You recognized that we had a decannulation and a large amount of blood loss. You correctly knew that we needed to come off ECMO, and you communicated to the team to get more people to go in emergency vent settings and to call the surgeon. A lot had to happen at the same time there. How did you keep it all in mind and prioritize it?
I just think that it comes down to the basics of coming off bypass. If you have a decannulation, calling for help, call the surgeon for sure, and call the blood bank because you're going to need a lot of extra blood products because of the blood loss. Yeah, it was pretty stressful, but it's a good scenario to practice.
Great job.